Welcome back to the deep dive. This is where we take your source material, cut through the noise, and really zero in on what you need to know.
The aim is always to get informed, quickly find those key takeaways, and hopefully make it all stick.
And today, we're tackling a condition that, well, it's rare, but it's serious, especially for young kids. We're diving into hemolytic uremic syndrome, or HUS.
Yeah, HUS. And our source material for this, it looks like some really comprehensive revision notes provided by you, the listener.
That's right. So our mission today is to work through these notes together, pull out all the high-yield stuff on HUS definition, causes, risks, you name it, right through to how it's managed and what the outlook is.
And HUS is, well, it's quite something because it often kicks off with a fairly common bug, but then it can escalate pretty fast because of a very specific cascade of events in the body.
Right. Understanding that cascade and who's most likely to be affected, that seems crucial.
Definitely.
Okay, so based on these notes then, how do we actually define HUS? What's the absolute core concept here?
Well, the notes lay it out very clearly. It revolves around a specific triad. Think of these three things as essential for the diagnosis.
A triad. Okay, what are they?
First up is microangiopathic hemolytic anemia, which is basically your red blood cells getting physically damaged, sort of shredded as they go through tiny damaged blood vessels.
Okay, so red cells breaking up in the body, small plumbing. Got it.
Exactly. Second is thrombocytopenia. That just means a low platelet count.
Right.
And third is acute kidney injury, sudden kidney failure, essentially.
Oh, okay.
So those three together, the damaged red cells, the low platelets, and the kidney failure. That's the HUS triad.
Right, so blood issues and kidney failure, all stemming from an attack on those tiny vessels. And the notes, they point to the usual suspect pretty quickly, don't they?
They certainly do. The classic presentation, what's often called typical HUS, usually follows an infection with a specific bacteria. E. coli 0157.H7. That link is absolutely key to remember.
And it's mostly a problem in young children, which is, particularly concerning. I saw in the notes, too, it's a notifiable condition in the UK.
It is, yes. Which tells you straight away about its public health significance. It's actually listed as a common cause of acute kidney injury in children, so that really underlines why spotting it quickly is so vital.
Okay. But it's not only E. coli 0157, is it? The notes mention other things, too.
That's right. While the E. coli is the dominant trigger for typical HUS, the notes are careful to mention other possibilities. Streptococcus pneumonia comes up, HIV as well.
And then there was this whole atypical category.
Exactly. Atypical HUS. This can be triggered by different things, like certain medications, the notes name ciclosporin and tacrolimus specifically, or it might be down to underlying genetic mutations.
Okay.
And importantly, the notes state that this atypical HUS is often caused by problems with the complement system, which is part of your immune response. It's a dysregulation there.
So that's a completely different mechanism compared to the bacterial toxin route.
Totally different, which, as we'll see, impacts how you manage it. It really shows that HUS isn't just one disease with one cause. It's a syndrome, a pattern that can arise from different starting points.
That makes sense. Which brings us nicely to the etiology, digging into those causes more deeply.
So as we touched on, the notes really hammer home that the primary cause, the source of typical HUS, is that Shiga toxin-producing E. coli, STEC, especially the 0157H7 strain. The Shiga toxin itself is the main aggressor here.
And how do people typically get exposed to this E. coli?
The notes list the usual routes: contaminated food, contaminated water, or even spreading from person to person. We often think of undercooked meat like burgers,
Yeah.
but the notes also highlight contaminated vegetables or fruit, unpasteurized milk or juice, contaminated water sources too, like lakes or pools.
And that point about kids, it's really striking. Over 90% of typical cases are in children.
Yeah, that figure jumps out, doesn't it? It's a really high-yield number to keep in mind. The notes do briefly list other bacterial causes, and then they sort of regroup the non-STEC causes. Again, medications, genetics, other medical conditions.
And that link between atypical HUS and the complement system.
Understanding that is crucial because, like I said, it points towards very different treatments later on compared to the typical STEC-driven HUS.
Okay, so we've got a handle on what HUS is and broadly what causes it. The next obvious question from the notes is, who's most at risk?
The notes paint a pretty clear picture here. Unsurprisingly, exposure to the bacteria through food or water is a major risk factor. So raw or undercooked meat, unpasteurized dairy, contaminated produce, contaminated water, all listed.
Makes sense. And what about demographics?
Young children are definitely the highest risk group. The notes specifically mention the age range of 6 months to 5 years. Older adults also get a mention, as do people with weakened immune systems.
I saw some slightly less obvious factors listed too, environmental ones.
Yeah, interestingly, it seems to be more common in the warmer summer months. The notes say June to September, typically. And perhaps surprisingly, more common in rural areas compared to urban ones.
Huh. Rural.
Well, that might tie into another risk factor mentioned, direct contact with farm animals or their environment.
Ah, okay, that connects the dots. And there was a specific UK public health guideline mentioned for kids with E. coli 0157, wasn't there?
Yes, a really important practical point. The notes state that children with a confirmed E. coli 0157 infection need 2 negative stool tests before they're allowed back to school or nursery.
That's key for preventing spread, obviously. A concrete guideline.
Definitely something anyone managing these cases needs to know.
Right. Let's get back to the mechanism, the pathophysiology. How does that Shiga toxin, or maybe these other triggers in atypical HUS, actually cause that triad of destruction?
The notes describe this cascade,
Yeah.
especially for the typical STEC US. It starts with the infection in the gut and the bacteria releasing the Shiga toxin.
And then the toxin gets into the bloodstream.
Exactly, it gets absorbed. And this toxin seems to have a particular liking for the endothelial cells, the cells that line your blood vessels. The notes say it damages this lining, particularly in the tiny blood vessels of the kidneys.
Okay, so damaged vessel walls.
Yeah.
How does that lead to the anemia, the low platelets, and the kidney failure?
That damage is the central problem. Red blood cells trying to squeeze through these damaged, narrowed, roughened vessels get physically ripped apart. That's your microangiopathic hemolytic anemia.
Ouch.
Yeah. Then platelets rush to these damaged sites trying to plug the gaps and start forming tiny clots. This uses up platelets like crazy, leading to the thrombocytopenia.
So that explains the low platelet count.
Precisely. And finally, all that damage and clotting happening within the small vessels of the kidneys just gums up the works. It disrupts their ability to filter waste, causing the acute kidney injury.
It sounds like a vicious cycle. Toxin damages vessels, damaged vessels shred red cells and chew up platelets, and the clots and damage wreck the kidneys. The notes specifically say clot formation makes it worse.
It's a perfect storm in the microcirculation. Now, because the symptoms, especially early on, can overlap with other serious things, gut problems, blood abnormalities, sorting out the differential diagnosis is really important. What else could it look like, according to the notes?
Well, the notes group it under the umbrella of thrombotic microangiopathies.
Right. Conditions where you also get clotting in small vessels. The main ones mentioned to differentiate from are thrombocytopenic purpura TTP and disseminated intravascular coagulation, or DIC.
Okay.
And the notes are clear. Telling these apart from HUS needs careful clinical assessment and specific lab tests. It's not always straightforward.
And given it often starts with diarrhea, you have to think about other gut issues too, right?
Absolutely. The notes list things like regular gastroenteritis, but also more serious stuff like appendicitis, inflammatory bowel disease, or even intussusception where the bowel telescopes in on itself, especially concern in kids. These can all present with bad abdominal pain and sometimes bloody diarrhea.
I see a few other specific conditions listed as differentials as well.
Yeah, HLLP syndrome, which is the serious complication of pregnancy. And the notes mention autosomal dominant HUS linked to genes like ADAMTS13, which, interestingly, is the same gene often involved in TTP.
Okay, so there's overlap there.
Definitely. And finally, inherited problems with complement regulation are listed again, linking back nicely to the cause of atypical HUS.
So clinicians need to consider a fair few things before landing on HUS.
Okay, let's switch to the numbers. Epidemiology focusing on the UK stats provided in the notes.
Right. The notes estimate the incidence is somewhere between 0.5 and 2 cases per 100,000 people per year in the UK, so quite rare overall.
And that age focus we keep mentioning.
It really comes through in the data. It primarily hits children age 1 to 4 years. The incidence specifically in kids under 5 is way higher. The notes quote 6.1 cases per 100,000 annually.
Wow. Yeah, that highlights the risk in that age group. And for kids who actually get infected with STEC, what percentage go on to develop HUS? The notes suggest about 20% of pediatric STEC cases might progress to HUS. And within that group, girls aged 1 to 4 seem to be at the highest risk.
Interesting.
There's another stat mentioned. In 2018, about 2% of all confirmed STEC 0157 cases in the UK ended up hospitalized for HUS, again, mostly kids under 5. Now, that 2% might sound lower than 20%, but it refers to all ages with STEC, not just kids, and specifically hospitalization for HUS.
Got it. And one point that really struck me from the notes was the delay possible between the initial gut illness and the HUS kicking in.
Yeah, that's critical. HUS can develop up to 2 weeks after the first symptoms like diarrhea start. You can't just assume someone's in the clear once the tummy upset seems better.
That's a crucial monitoring point. Any other UK-specific trends mentioned?
The notes mentioned that Scotland has seen significant VTEC outbreaks, sometimes linked back to butchers, which just reinforces that food source connection.
And the atypical forms, how common are they?
The estimate in the notes is around 10% of all HUS cases fall into the atypical category. Globally, HUS happens everywhere, but reporting might be lower in places with less developed healthcare.
And just to recap the timeline quickly, STEC incubation is usually 2-4 days. Then HUS typically starts within 7 days of the VTEC symptoms, but could be as late as 14 days after.
Those timelines are vital for clinical suspicion in tracking contacts. So, what does HUS actually look like clinically? When someone presents, what are the signs and symptoms described in these notes?
It often kicks off, maybe surprisingly, with diarrhea that isn't bloody at first.
Right. Profuse, watery diarrhea is common initially, and then it typically turns bloody maybe 1 to 3 days later. That change is a key part of the story.
And then beyond the gut stuff, the effects of that triad start showing up systemically.
Exactly. The notes list fatigue and pallor, looking pale because of the anemia, and then bruising easily or seeing petechiae, those piney red or purple spots because of the low platelets.
Yeah, those map perfectly onto the first two parts of the triad. What about the kidney side?
Key sign is reduced urine output, oliguria, or even anuria. That's a major red flag. You might also see other signs of kidney dysfunction on tests and edema or swelling because the kidneys aren't getting rid of fluid properly.
Is fever common?
It can be part of the initial infection, but the note suggests it's often resolved by the time the HUS symptoms really bring someone to medical attention. Abdominal pain, though, seems to be a big feature throughout.
More severe pain than typical tummy bugs.
Yeah, the notes specifically say the abdominal pain in STEC colitis leading to HUS is often more severe than in other types of bacterial colitis.
And in the most serious cases, it can go beyond the kidneys and blood.
Correct. Severe HUS can lead to neurological problems, confusion, seizures, even stroke, and potentially failure of other organs, too.
It sounds like a really challenging presentation. So, what investigations are key for diagnosis, according to the notes?
Okay, the workup. Cord blood tests are essential. A full blood count, or FBC, is needed to spot the hemolysis evidence of red cell breakdown, confirm the anemia, and see that low platelet count.
And check in the kidneys.
Absolutely critical. Renal function tests and electrolytes, UNEs as we call them, are needed to assess kidney function directly. Liver function tests, LFTs, are usually done too.
I saw LDH mentioned specifically.
Yes, lactate dehydrogenase, LDH. It's often elevated quite early on because of the cell damage and breakdown, so it can be a useful marker. CRP to check for inflammation, and a clotting screen are also standard.
And to actually nail the cause,
Yeah.
especially for typical HUS.
Stool testing is key. Looking for the Shiga toxin itself or the specific STEC bacteria, like O157-7. And a urine analysis is important too, looking for blood, hematuria, or proteinuria, as signs of kidney damage.
What about investigating those atypical cases? They sound trickier.
They are. The note specifically mentioned considering complement gene analysis, looking for those underlying genetic mutations affecting the complement system, and also measuring AMTS13 activity.
Why at NTS13?
Because low levels of AMTS13 activity are characteristic of TTP, which is a key differential diagnosis. So checking it helps distinguish between atypical HUS and TTP.
Right, that makes sense. And a practical point from the notes. Repeat these tests if the patient isn't doing well.
Essential. Things can change quickly, so monitoring is key. Okay, now perhaps the most important part. Management. How do we treat HUS based on the UK focus in these notes?
The headline seems to be supportive care.
That's absolutely the cornerstone, especially for typical diarrhea-associated HUS. The main focus is managing the complications, the kidney failure, the anemia, the fluid balance, rather than attacking the underlying process directly. This almost always means hospital admission.
So not really a specific cure for the HUS itself, particularly the common E. coli type.
The notes really emphasize this. For typical HUS, there aren't specific proven treatments beyond that supportive care. So interventions are things like careful intravenous fluids, blood transfusions if the anemia is severe, and importantly, dialysis if the kidneys fail badly.
And here's a point that really jumped out at me, something that might feel counterintuitive. Antibiotics are not recommended, even if you know E. coli started it.
This is such a critical takeaway from the notes. Giving antibiotics to someone with an active STEC infection can actually cause the bacteria to release more Shiga toxin, potentially making the HUS worse. So standard practice is to avoid them.
That's crucial. What about treatments for the atypical forms or very severe cases?
The notes do mention some specific strategies there. Plasma exchange is sometimes used for severe non-diarrheal HUS, which would include some atypical cases, and eculizumab is mentioned specifically for adult atypical HUS.
What's eculizumab?
It's a monoclonal antibody that inhibits part of the complement system, C5, so it directly targets that underlying mechanism in many atypical HUS cases.
Ah, okay, a targeted therapy.
Yes. For atypical HUS more generally, the notes also list plasma exchange, giving factor H concentrate if that's the specific deficient protein, or potentially kidney transplantation if the kidneys fail completely.
So it boils down to mainly supportive care for the common type, but these more targeted, often complex treatments might be options for the rarer atypical forms. And one last UK point on management report it.
Yes, it's notifiable. Cases must be reported to the local health protection team, essential for tracking outbreaks and public health. The notes do mention that novel things like other complement-blocking antibodies are being looked at, but again, reiterate the lack of established specific treatments for typical HUS beyond support.
Okay, so given all that, what's the likely outcome for patients? What do the notes say about prognosis?
It's variable, as you might expect. Depends on how severe it is, the patient's age, whether there are complications, and importantly, how quickly treatment was started.
And that difference between typical and atypical HUS matters here too, right?
Very much so. The notes state that typical HUS, the kind following the diarrheal illness, generally has a good prognosis, especially in children. Most kids recover well.
That's reassuring.
It is. However, the notes add a significant caveat. Some patients, estimated at 5 to 25% of typical cases, can be left with long-term kidney damage, like chronic kidney disease or hypertension.
Okay, so recovery isn't always complete. What about adults or severe cases?
Generally a worse prognosis for adults and for anyone with very severe disease, especially if it affects organs outside the kidneys. Fatality is linked to severe extrarenal problems, and the risk is higher in infants, very young children, and the elderly.
In the atypical form.
Unfortunately, atypical HUS often has much poorer outcomes, with higher rates of death and progression to end-stage kidney disease requiring long-term dialysis or transplant.
Right. Knowing the risks and outcomes, how do we try and prevent HUS from happening in the first place? What preventive measures are listed?
Prevention is key. The notes mention it at different levels. For the food industry, it's about minimizing fecal contamination during meat processing, particularly cattle.
On a personal level.
Good old-fashioned hygiene. Thorough hand washing, especially after using the toilet or handling raw meat and before eating. Safe food practices, cooking meat properly, washing fruit and vegetables, avoiding unpasteurized products.
Public health has a role too.
Definitely. Early diagnosis of cases and rapid identification and control of outbreaks are crucial. That notification system we mentioned is part of this.
Any mention of vaccines.
The notes do mention conjugate vaccines against E. coli 0157, but they add the important phrase, not widely available yet. So, it sounds like they're either still under development or not part of routine immunization schedules currently.
Okay, so prevention largely relies on food safety, personal hygiene, and public health surveillance, for now. Lastly, let's touch on complications. If someone develops HUS, what other problems can arise, according to the notes?
They list potential complications by body system, starting with the gut, even after the initial illness, problems like intestinal strictures where the bowel narrows, or even perforations. Also intussusception, rectal prolapse, pancreatitis, and just severe ongoing colitis.
Some serious GI issues there. What about neurologically?
The notes list altered mental state stroke, cerebrovascular accident, and seizures. It really highlights that the damage to small blood vessels isn't just confined to the kidneys.
And even though kidney injury is part of the definition, there can be further renal complications.
Yes, the acute injury can unfortunately lead to chronic problems. The notes list chronic kidney disease developing later, ongoing hematuria or proteinuria, and hypertension, high blood pressure as long-term possibilities.
So surviving the acute phase doesn't always mean the kidneys are completely back to normal. The notes really stress that close monitoring and managing these potential issues are vital.
Absolutely. It requires ongoing care and vigilance, potentially long after the initial hospital stay.
It's quite striking how something like a common gut infection, or perhaps a less common genetic glitch, can trigger this really specific devastating attack on the microvasculature, leading to that distinct triad.
It really is, and that clear split the notes make between the typical toxin-driven HUS and the atypical, often complement-driven HUS with their different triggers, treatments, and prognosis, it highlights the complexity, doesn't it?
It absolutely does. It shows we're dealing with a syndrome where the underlying cause really dictates the path forward, even if the initial clinical picture, that triad, looks similar.
Yeah, and it also highlights, particularly for the typical form, that even when we understand the mechanism pretty well, the toxin damaging the vessels, we still lack specific treatments beyond supportive care. That remains a challenge.
A really important point.
Mm.
So this deep dive into your notes on hemolytic uremic syndrome has covered a lot of ground. That core triad definition, the E. coli O157 link versus atypical causes, the risk factors like age and exposure, the pathophysiology of vessel damage, the key differentials like TTP and DIC, those UK stats and timelines.
The clinical features from diarrhea to kidney failure, the essential blood and stool tests, the crucial supportive management, especially avoiding antibiotics in STEC cases, the variable prognosis, prevention strategies, and that list of potential complications across different body systems.
We've really tried to follow the structure and pull out the most vital information from the material you provided.
Hopefully, this discussion gives you a solid framework for revisiting your own notes, maybe reinforcing those key points we've talked through.
Absolutely. Use this as your guide. Thank you for joining us for this deep dive into HUS.
Thanks for bringing the topic. Until next time.
Keep exploring, keep learning.